umbrella, there are about 50 to 60 trainers that he sends all over the world to guide us in the performance of HIFU. And I think what they've spoken is HIFU is promising as an alternative and maybe gives an answer to all those difficulties we face if we do laparoscopic myomectomy. All of you, for question and answers, you can either raise your hand if I can see you, or you can write it down, or your questions. But I would like to take this opportunity just to have a special request to Professor Osamu Dzumi. Hi, Professor Osamu Dzumi, can you hear me? You have to, your microphone has to be on. Okay, Professor Osamu Dzumi, I know I have a special request because I came across a Japanese paper. It was a classification of adenomyosis by a Japanese group of doctors. I thought you're the best person. To explain because not many of us read Japanese. Can you please show us your presentation, the classification of MRI classification of adenomyosis? Over to you.
Okay. I'm a laparoscopist and also reproductive laparoscopist. So I'm very interested in adenomyosis. And this time, I'm going to explain Japanese paper. This one. And
I think it's this one.
Yeah.
Okay. And
Yes.
Can you?
Yes, I can see your painting. Yes.
You can see. So, yeah. Some Japanese describe the paper and origin of adenomyosis, maybe subtypes, 3 subtypes. And one is intrinsic invasion from endometrium.
Mm-hmm.
And second one, this is as shown in the slide. Yes. Intrinsic one and most popular cases are 59. And second one is extrinsic. Their invasion from outside. Okay. And third one maybe you can see in the slide, figure 3. Yes. And de novo intramural one, maybe de novo adenomyosis. And number of cases 22. So there are several pathophysiology of adenoma, and we may treat depend on the pathophysiology of the adenomyosis. And I'm interested in application of HIFU because surgery is sometimes very difficult for adenomyosis. Okay.
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 Thank you very much. We will have more discussions on adenomyosis in episode 4. We'll come back to adenomyosis in episode 4. But right now, are there any questions from the audience? If not, then let me ask the questions that was asked in the last episode, let me go to the laparoscopic surgeons, the presenters on the first talk and second talk. Professor Bernard Chen and my good friend, Dr. Bay Swan Tiong. There's always this perennial question. Is there a size of the fibroid that you would tell your younger doctors not to operate? In other words, is there a limit to the size of a fibroid that you would not operate? Maybe is Bernard there?
Yes. Can you hear me?
I can hear you.
Okay, great. Okay, so well, I heard your questions. Well, essentially, there's no hard guidelines as to what is the upper limit of the size of a fibroid before we would embark on laparoscopy. Again, size, in many things, is relative. So we always tell our colleagues is that it's not an absolute number, but it's something that you want to look at the patient as a whole, such as the patient's build, of course, the size of the fibroid, previous pregnancy, etc. That will make a lot of difference when you come to performing laparoscopy. For example, I mean, if you have a patient who is 1.65 meter tall and then had delivered 2 babies before and now have a fibroid of about 10 centimeter, it will be very different for the surgeon if the patient were to be 1.55, never delivered baby before, fibroids the same, 10 centimeter. So I think that's why this, we always say there's no real absolute numbers to follow. But in general, for Asian population, I would think that you want to perform surgery comfortably, laparoscopy without unduly prolonged surgery, prolonged surgical time. 10, 12 centimeters will be, I would think, will be something comfortable for most of our colleagues. And of course, the other factor to consider is also the number. We are not looking at the size alone, but how many fibroids the patient has. In fact, we were doing quite a few surgery the last 2 weeks. Previous week, we have a patient who had not so big fibroids, but there were many of them. I think we removed about 8 or 10 fibroids, but they were like in the range of about upper range of the size was probably about 7 to 8 centimeter. But it took a long time because it's a repetitive surgery. Take out one, take out another one, take out another one. So if you to compare somebody who has 6, 7 cm fibroids, but there were multiple of them, then compared to somebody who has one single fibroid, 10 centimeter, one single piece of it, then I would think that maybe the one single piece, 10 or 12 centimeter, could be easier to perform. So again, as I say, I think to summarize, there's really no hard and fast rule as to what is the correct size to do laparoscopy. Is relative. Other factors to consider including the patient's physics, including the patient's parity, and of course the number as well. I hope that sort of explained.
Thank you. Okay, quick question. I know you are the teaching professor and you have a lot of younger doctors under you. So do you morcellate within the back in laparoscopic myomectomy?
Well, actually, ever since the pregnant women and children incident, we have been trying out the various containment technique. So ever since then, in fact, we have been largely performing our power morcellations in back. Today, if you look at AAGR, I think we have been starting doing this both. Initially, we started performing morcellation in back for older women, as what Dr. Bay has mentioned, because the risk of coming across a leiomyosuck, basically you are looking at the older patient. Just look at a brief sharing of the statistics that I've seen over the last 10 years. I'm looking at about 1 in 1,000. Laparoscopy, we will see about every 1,000 cases, you probably see about one leiomyosarc inadvertently morcellated. So the number is not that big. But of course, if you look at everything, look at all the various literature, you're looking at 0.1 to 0.5. I think all these are numbers reasonable depending on selection of cases and so on. So if you look at the number, yes, it's not high. If you look at 40 and above, basically most of the in fact, all the patients that we encountered leiomyosarc inadvertently morcellated were patients in the older age group, 40 and above. But of course, if you look at the literature, you know that leiomyosarc can even occur in women who are even younger than that, maybe in their 30s. And the other consideration, as what Bei has mentioned, is that because we do see disseminated leiomyomatosis. In fact, we have one patient now pending surgery. The patient has a previous laparoscopic myomectomy, and unfortunately, I think she has growing lumps and bumps everywhere in the peritoneal cavity. And this is not the first time we have seen cases like that. So that's why, to mitigate this so-called complications of morcellations, we feel that morcellating in the back makes sense. And I think it is technically not difficult. It's just that we retrieve ovarian specimens or other specimens in the back most of the time. Even if we just do a salpingectomy for ectopic pregnancy, it's good to use a bag to scoop it up so that to minimize spillage of whatever content, be it POC, be it ovarian cyst. So I really don't see a big concern as to why, just because it's a fibroid, we are treating it differently, because we do know the inherent risk, be it disseminated benign diseases or disseminating a cancer.
Okay, thank you. Okay, let's hear from Professor Osamu Tsuzumi, the land of the rising sun. Okay, you have to unmute, Professor Tsuzumi. Yes.
We usually use in-back morcellation. Yeah. Mostly, our patients are conscious about the FDA program. So they ask, is it safe? So we assure you, them, in-back morcellation is safer. So mostly we use in-back morcellation, but not all in Japan, of course.
Okay, what about you? Do you have a guideline? How big a fibroid you to me? Do you have such a guide? In other words, if it's more than do laparoscopic myomectomy or you do open myomectomy?
In case of huge one and maybe 5 or 10 fibro, we use laparoscopically assisted myomectomy. Maybe 3 centimeter incision. We apply LAM, laparoscopic assisted myomectomy, and maybe 6 centimeter single one with laparoscopic myomectomy, and larger one and multiple one we use laparoscopy and assisted one. Yeah.
So in all your experience, for so many years, how many leiomyosarcomas have you come across?
We can exclude sarcoma by MRI and blood testing. And I have never experienced malignancy during this 20 or 25 years experience.
Okay, so it's again very rare. Let me come to the most difficult part for my good friend Dr. Bei Suan-Tiao, who is sitting so comfortably there. Okay, Dr. Bei, do you have, since you are in private practice, and well, we always say in private practice we are literally alone, do you have a guideline on, say, the number of fibroids you do laparoscopically or the size of the fibroid you do laparoscopically? And do you morcellate? Do you still morcellate in a bag nowadays?
Thanks. Thanks for the questions, Kim Wai. Essentially, how hard I try to do the laparoscopic myomectomy, I think to me, one of the important criteria is the future fertility requirement of the patient. For those that no longer desire future childbearing, I'm quite gung-ho in a way that if you really want to, I'll basically try my best to achieve that, because most of the time we should be able to control the hemorrhage and able to achieve complete the surgery without much problem. However, I have reservations coming to patients who still wish to become pregnant or have infertility as a problem. I will be much more careful in a situation like this. And in fact, if they have a deep-seated big intramural fibroid, I would be rather reluctant to actually offer them laparoscopic myomectomy. No doubt, laparoscopic suturing can be done pretty well, but I feel somehow at the bottom of my heart that I perhaps can do an even better job openly. So that's one thing. And the next question is about how often do I use the morcellation bag? Well, I'm a visiting faculty to MIS unit in KK, so I'm somehow impressed by them as well, especially when they warn me about all the scary tales. Right now, what I do personally is that for the younger patient, those that is below 40 or 45, I do still do naked power morcellation, in other words, without bag. And I enjoy doing it without condom. Right, but for the bigger one and older patients, yes, I would tend to use morcellation bag nowadays.
So in your so many years, 20 over years of experience in this, how many fibroids have you come across that's leiomyosarcoma? I just want to have a consensus.
None. I have not come across one. Fortunately, touch wood. Yep.
None is an honest answer.
Yep.
To many of us.
Yep.
Okay. All right. That's a question from Dr. Bachu Singh. Dr. Singh, could you please introduce yourself and ask a question? Dr. Bachu Singh. So how do I? So I do it or they do it?
They do it.
Okay. Can the controllers please tune in to Dr. Bachu Singh? Yes. Dr. Bachu Singh, yes. Yes. Unmute. Okay. Okay. While you're figuring out who is who, can we go on to Dr. Ishaq Abdul? I think he's on the line now.
Yes. Good day to everyone. I just want to thank you for giving us this highly elucidating presentations. Thank you very much. My question goes. Sorry, my name is Ishaq Abdul, a professor. A professor of Obs and Gynae from the University of Ilorin, Nigeria.
Okay, good.
Good. And I'm quite interested in this new technology because of so many advantages that have been listed. I just want to bring out my concerns as regards the sizes of the fibroids after HIFU. It does look to me that it takes a little while before normal sizes are returned to by the, in the treated fibroids. In the treated uterus or uteruses. is this usual observation, or it takes a little while before the uterus return to normal or close to normal sizes?
Sorry,
You don't understand my question. My question is, after HIFU, after HIFU treatment, I tend to see that the MRI scans still show a bit of enlargement of the uterine size.
Okay.
So how long does it take for the uterine size to return back to normal sizes, even after the shrinkage of the fibroid volumes in them? It didn't look like it goes back to normal quickly.
Sure. I leave it to Professor Zhang Lian to answer that. Professor Zhang Lian, can you please answer the question?
Yes, actually, like the average shrink rate is like 3 months. The shrinkage is like 30%. 6 months after HIFU, shrinkage rate was around 50%. Like I already showed, like in my PowerPoint, in my one slide, like at the end of the 3 years, 90% of the shrinkage of that. So it depends. Like the case I showed you, and like just 4 months after that, the size of the uterine almost getting normal. So it depends on the size of the fibroids and the number of the fibroids. So
thank you very much.
I can just tell you the average shrinkage rate of the uterine fibroids. But it can be getting normal, you know, in some time after HIFU.
That's quite reassuring. Thank you very much for your presentation.
Thank you.
I appreciate you. Thank you.
I think his main point is he noticed that the fibroids had shrunken in size. I think that's what he's trying to ask. But let me follow on that. You see, I think I give an example of adenomyosis. Adenomyosis hasn't really got a border. So, and to do an MRI post-operatively to check on the adenomyosis is very expensive in Singapore. So what I do is, instead of trying to figure out where the borders of the adenomyosis by using MRI, I measure the whole uterine length, size, and depth. And you find that, yes, in adenomyosis, once you're treated, they do shrink in size. And if you have done ultrasound follow-up of the fibroids that has shrunken, most of them, I would say, would have reduced in size. Okay, I think we have a question from we got Dr. Batu Singh on the line. Dr. Batu Singh, could you introduce yourself? Dr. Batu Singh, can you hear me? I think your sound is off. You have to unmute your sound. Please unmute. Yes. Looks like unmuting is a problem. Huh? Sorry, Dr. Batu Singh, can you please unmute your microphone? Any more questions? Yeah. Okay, while you're trying to look for the button to unmute, maybe we take this opportunity to ask Professor Zhang Lian, which is the question that everybody asked. Can MRI help in the diagnosis of leiomyosarcomas? I think you have the most experience on it. Can you show your slides now?
Sure, thanks. Just a moment. So this, yeah. So I just made this slide today. Actually, this just Dr. Wang Qian and Professor Li and Dr. Li, you know her. So she did this review, actually retrospective review from 9 centers, 9 hospitals between 2008 to 2019. So the total patients was more than 15,000. Actually, initial diagnosis of uterine fibroids that came for HIFU treatment. Then came to, after review the MRI, 46 patients were suspected to be sarcoma. And those 46 patients were sent to for open surgery. And 12 of them were confirmed by surgery was sarcoma, but that is not leiomyosarcoma, but endometrial stromal sarcoma, most of them. So it's different from the publications. And also the other 50,713 patients underwent HIFU treatment. And because at the beginning, for the MRI, actually, we were not so sure if you can make the diagnosis accurately. So we have another, to the follow up, just to make sure if some patient misdiagnosed. So among these patients, 8 of them were suspected to be sarcoma at the 3 and 6 months follow up after HIFU, and 6 of them were confirmed by surgery. But it's because HIFU was used to treat even malignant tumors. So for those cases, we didn't have the catastrophic consequences after that, because after surgery, no other bad consequences. So here, for the answer, I think MRI really helps. Like the pre-HIFU, even pre-laparoscopic, I think MRI really helps. So like for those 15,000 cases, totally 18 cases were sarcoma. Like the ratio from this group of patients for this population is like 101%. So it's very low, but the difference just like these lots, most of them like the endometrial stromal sarcoma. So probably just because of the age of this patient, they are younger, because when this thing comes to for HIFU treatment, they are younger than those. The average of this patient is around 41 years old. So this probably just because of this reason. Actually, for the MRI, you can say from here, and why we often use T2 weighted image. This T2 means like you can see the water, like the bladder white. So that's T2. So T2 weighted image for uterine fibroids may be hypo intense, like the black. And here, hyper intense fibroids, it means white. So from there, you can see the margin was clear, either this one and this one. And for the contrast ultrasound, usually we don't see the margin or is clear. And you see the perfusion was even for this one. But for this, you can see even like this shape was round, the shape, and also margin, and also the intensity on T2 weighted image. And from this one, you can say completely different. Like this one, the shape was not round, is irregular. And also you can see the hyper intensity on T2. And you see lobulated the fibroid here. So you can see even from the contrast is different. So from this image, we can tell the difference between these two. So like this case, leiomyosarcoma, like this case, even like this part, this fibroid, and here, hyperintensity and some necrosis in the tumor, and the contrast, low perfusion in this area. So this part was confirmed sarcoma. The outside this area, uterine fibroids. So that's why this, I think this evidence, some uterine fibroids can become like leiomyosarcoma in the future. So I just want to share with you some like cases. We already knew about the different MRI features. Like this case, how about the diagnosis? Probably we don't know, but we can say this is not uterine fibroids because you can say MRI hyper intensity on T2 because white. And the margin, we cannot see the margin here. So, and also the contrast ultrasound, a contrast MRI, contrast enhanced MRI shows there was low perfusion, poor perfusion in the center. So the margin was not clear. For this one, if you cannot, you don't know if it's a sarcoma or something else, but you can make sure that's not uterine fibroids. Actually, these features are sarcoma. So like this case, when you have more experience, you know exactly what it is. Even like at the beginning, my group, my doctors, when they're younger, probably at the beginning, they don't have that much experience, but now they are experienced with reading MRI. So for this one, hyperintensity on T2, margin is not clear, necrosis is observed in the tumor on contrast MRI. Of this, it helps us to make the diagnosis. And this one actually I just got last week. And my doctor from another sent me this image because after she reviewed this patient, this MRI of this patient, she said, hey, I suspect this one is sarcoma. She sent this to me. I said yes, because on T2 weighted image, hyper intensity. Compare this one with this one. This uterine fibroid, but this one hyper intensity. But you can see here, multiple nodules or lobulated inside. And for the contrast enhanced MRI, we see necrosis here. Also, the margin was not clear. So we made the diagnosis. We said this is a sarcoma, just sent to for the open surgery. And after the surgery, actually during the treatment, during the surgery, the frozen section examination showed malignant, but didn't make the diagnosis. And here, after that, the final pathological diagnosis was leiomyosarcoma, this one. This one, benign. So even from this one, we can see the difference. So I think it helps a lot. Thank you. That's what I want to share with you guys.
Okay, I just saw a little image of the slide which shows the complications. You might as well finish and tell us what are the common complications in HIFU treatment of fibroids or adenomyosis. I know
okay. Okay, thanks, Dr. Lee. Actually, this one I just leave this here. This is from my paper we just published in 2018. Actually, more than 20,000 patients from different centers, like the real world data. So from here, you can say the most common complications, just like class A, just like some pain, something like that, you don't need any treatment. And also class B, maybe lower abdominal pain, and because this pain is different from this one, maybe severe, longer, but low, don't need any treatment for this one. So I think we should pay attention, like say class C and D, class C above. For this one, like skin burns, that's the most common complications during HIFU treatment for uterine fibroids and adenomyosis. But you can say right now, the incidence, just like 0.14%, which is very low. And also some patients have the leg pain. Also, like the class C and class D, the big number, just like below 0.5%. It means right now this technique is very safe. So here I just want to show you the serious complication of class C and above in each year. 2011, you can say almost 1%, but 2012 is around 0.6%. And after 2014 is below that. And you can say right now with the improvement of the technique and also the experience of the doctors have, these complications decreased. So right now I think it's pretty safe for this technique. Thanks.
Okay, thank you. Can you go back to your first slide on the class A, B, and C again?
Yeah.
Okay, sure. This just for the benefit of those younger doctors, what Professor Chang has done is class A very mild. In other words, mild low abdominal pain, which you get it anyway in a laparoscopy or laparotomy. Sacrococcygeal pain is 10%. If you lie something on the flat surface for too long, we get it. Abnormal vaginal discharge is very common after surgeries, lower limb parastasis, nausea, vomiting, you get it also after anesthesia, erythema on the skin, redness on the skin, we get it also when you put the plaster on the skin, fever, which is actually a post-operative reaction, very common, hematuria, we get it when you put the Foley. So I'm very happy that under class D, which is a concern to many of the laparoscopic surgeons, is your bowel injury is very low, and this 0.01% is much lower than if we would have done through open surgery or laparoscopic surgery, and I don't see any of these scary blood vessel injuries like we normally encounter rarely in laparoscopy or laparotomy. Thank you very much, Professor Chang.
Thank you.
So have we got back? Can we go back to Dr. Singh? Have we got him again? Well, I saw a hands up for a long time, Dr. Bachut Singh. If not, then are there any more questions from anybody else? I see. Nobody else. Okay, sure.